And that leaves us with the question of, should everybody who was eligible for that trial get regional nodal radiation? And I think that most people think that's too much. 40% of the patients on trial had no lymph nodes that were positive, so that's a low-risk population. It is a trial that largely predated sentinel lymph node biopsies, so many of the node-positive patients that you would meet today who've had a positive sentinel node might have actually been node negative on that trial, so you have to sort of weigh that into it. I think that for most of us, the real effort now is to try to determine who has a high enough risk of distant recurrence or overall recurrence that the benefit is going to be there for them and really outweigh the toxicity. So in our practice, we're not offering it to everyone who's node negative, but we certainly are advising patients of the results of the trial and really trying to work with them to look at their individual risk factors and offer it to people who have reasonable risk and might really have benefit from it. I think the thing that it highlights is how desperately we need a predictive assay so that we could really identify patients who are going to have benefit from radiotherapy and even get to a place where we could actually determine what's the best dose for that individual, so we're not giving everyone the same dose. And there's been a lot of progress on that front, both from a scientific standpoint and from a clinical trial standpoint, but there's still room to go.